Let me thank Sri Lanka College of Endocrinologists for inviting me to give this talk today. It's a great pleasure and privilege to be here. Now, this is a bird's view of Flinders University and Flinders Medical Center, where I work, and both institutions are co-located in south of Adelaide. As you know, Adelaide is the capital city of South Australia. Let's look at a bit more deeply into the subject of insulin, self-monitoring of blood glucose level, and how do those two affect the quality of life. Now here on, I will use the acronym SMBG to denote self-monitoring of blood glucose level. Next 15 minutes or next 20 minutes or so, I would endeavor to cover some important aspects of the subject, which include a place of SMBG in the management of different types of diabetes, effect of SMBG and insulin on quality of life, what is the trade-off between SMBG, insulin, and quality of life, followed by how to improve health-related quality of life in insulin-treated diabetic patients. As we all know, diabetes is one of the most serious global health-related problems, the incidence of which has gone up significantly over the past several decades, and it continues to grow very rapidly. Unfortunately, it's a condition, unless you treat it properly, manage well, can lead to life-threatening complications, particularly life-threatening vascular complication. In the context of a management plan of diabetes, it's widely recognized that insulin and SMBG are integral part of this complex and integrated management care plan for our diabetic patients. Now, before dwell into how these aspects, insulin and SMBG, affect quality of life, let's look at what is quality of life. It can be defined a number of ways. That's one of the problems with this area, because there's no one uniform definition. Hence, it's very difficult to incorporate this concept into a scientific study or a measure objectively. If you look at one of the definition, it says quality of life is an abstract, multidimensional construct reflecting physical, psychological, and social aspects, including but not limited to the concept of health. So there are a lot of technical jargons here. What does that mean in lay term is that the level of satisfaction and comfort that a person or group enjoys. Why do we consider quality of life? This is due to a number of reasons. The most important ones are that any therapy or any investigations which improve health-related quality of life have better compliance, and as a result of that, a better outcome. And also, lower incidence of mental health-related problems like depression and anxiety. That is why current guidelines advocate quality of life as a treatment goal in addition to your HbA1c target, or lipid target, or your blood pressure target. So health-related quality of life is as important as other goals that we would like to achieve in our diabetic population. Self-monitoring of blood glucose level, as I mentioned earlier, is an integral part of complex integrated management plan of our diabetes. It's a useful tool, there's no doubt about it. It helps us to guide the diet and exercise therapy for our patient. And it also helps us to select or choose appropriate anti-diabetic medication, and also prevent complications such as hypoglycemia, and helps us to make sure that we maintain an adequate glycemic control with a view to preventing future vascular complication. Unfortunately though, this self-monitoring of blood glucose is associated with poor quality of life. It has a negative impact on quality of life, unfortunately. So therefore, we have to be very careful before we recommend to our patient that you should do your blood glucose level 6 times a day or 4 times a day. It's very important that what we want to achieve in our patient. So the question here is, does every patient with diabetes need to do self-monitoring? It has been shown over and over again that value or SMBG for patients with non-insulin treated type 2 diabetes is very controversial. In fact, there were 2 highly significant systematic reviews and meta-analysis done and published by Google group, Cochrane group, suggests that there is no scientific evidence to say that a blanket recommendation of patients who have type 2 diabetes who are not on insulin to do their blood glucose level multiple times a day. And also people who do their blood glucose level. The frequent question is that how many times I need to do blood glucose level. Again, whether it is more frequent or less frequent, there is no significant effect on HbA1c or glycemic control. So then what's the most appropriate way to prescribe self-monitoring? Again, there is no consensus. But however, what's called structured SMBG or structured self-monitoring of blood glucose level, it indicates that the patient knows how to do it properly, how to interpret the results, and also how to interpret the trends and patterns of blood glucose levels and act upon it. That's called structured blood glucose measurement. In fact, the studies have shown that if you do inform our patients about all these aspects of self-monitoring, and if the patient can perform it to the satisfaction of the medical profession, then it might have a beneficial effect. Just doing a random blood glucose haphazardly is just a waste of time and resources. Now, this particular study was looking at the blood glucose control in the form of HbA1c, and there are 3 groups of patients in this particular study. This is a randomized open label study. The one group did not do blood glucose level. The other 2 groups did check their blood glucose level. One group had instant message prompting their blood sugar level and the timing to the meal, as well as what time and the day the blood sugar was done. And the other group did not have instant message. Now you can see that whether there is instant message or not, there is no difference at all in terms of HbA1c. However though, the patients who did not check their blood glucose level when compared to patients who did check their blood glucose level have a higher HbA1c. But this difference tends to reduce as the time goes on. At the end of 1 year, hardly any difference between the groups. So what does that mean? It means that even if the patient does multiple blood glucose measurement and interpret properly, the beneficial effect lasts less than 1 year. So there is no reason for us to advise our patient to go on and checking their blood glucose level when they are not on insulin and their blood glucose level is reasonably well controlled. So therefore, patients and physicians must actively engage in performing, interpreting, and acting on self-monitoring of blood glucose values. Unless you do that, there is no rationale of doing it, just for purpose of doing it. Current evidence suggests that SMBG should not be routine for most patients with non-insulin treated type 2 diabetes. However, initiation of new medication or medication dose change would require you to advise those patients to do their blood glucose level at least for a few months until their blood glucose levels are reasonably under control. There's no doubt that patients who are on insulin and type 1 diabetic patients, SMBG has definite place and it is beneficial in terms of keeping their glycemic targets achieved and also preventing complications such as hypos. What about continuous glucose monitoring versus finger pricked blood sugar measurement? It has been shown that continuous glucose monitoring has beneficial effect in terms of less negative impact on quality of life, preventing hypoglycemia, and achieving HbA1c target. One of the problem with continuous glucose monitoring is that the cost involved with the glucose sensors, and majority of our patients unable to afford continuous glucose measurement. So as I mentioned earlier, it has less negative effect on quality of life. So if your patient can afford, certainly continuous glucose monitoring has a definite place in the management of diabetes. Let's look at the natural history of diabetes. As you well aware, as the time goes on, the beta cell mass gradually decline. And if the patient lucky enough to survive for about 15, 20 years, most of them end up in having absolute insulin deficiency and requiring insulin for their diabetic management. Insulin therapy has a negative effect on health-related quality of life. It's mainly because of the complex nature of the treatment. Patient need to be on multiple injections, multiple types of insulin, increased risk of hypos, increased self-monitoring to prevent hypos. All these things contribute to a negative impact on quality of life. Therefore, it's very important that we teach our patient, educate our patient about insulin therapy well before they require insulin treatment for their blood sugar control. So you need to start this dialogue well before and show the diagram that I showed you to the patient and say that if you live 15 years or 20 years, you will end up in having requiring insulin. So that's not because your fault, that is the natural history of the patient. You try to allay the anxiety, try to remove that guilt feeling of your patient. It has been shown that simple regime, like once a day or max twice a day for insulin naive patient is as effective as 4 or 5 times a day of insulin and has less negative effect on quality of life. So insulin therapy, how can we optimize the quality of life while controlling their diabetes using insulin? As I mentioned earlier, a clear communication, set up goals, use simple regimes, and educate the patient how to inject their insulin properly without causing much pain. And the simple regime is very helpful in improving the compliance of our patients. And it has been shown that certain studies have shown that rapid-acting insulin may be beneficial compared to short-acting insulin. It is probably attributed to less interference with patients' day-to-day life. For example, if your patient is on, say, Actrapid, it has to be given 20 minutes before the meals, whereas the rapid-acting insulin like Humalog or NovaRapid, it can be given just before or just after food. and also less risk of hypos. Premix insulin has better quality of life. Reason is that patient doesn't have to inject 2 injections at the same time. And it has been shown that insulin pump, this is particularly in patients with type 1 diabetes, has positive impact on quality of life. Now this particular study looked at diabetic control and how it affects the patient quality of life, and the quality of life measured using utility. Utility is a measurement of desirability of a given health outcome in terms of health-related quality of life. The better diabetic control has a better positive results on quality of life and vice versa. This is looking at the disutility, the opposite of utility, on how does the number of injection affect the patient quality of life. The lesser the number of injection, better the quality of life, or lesser the disutility compared to multiple injections a day. So simple regime using once a day or maximum twice a day insulin for insulin naive patient will help to improve compliance and less interference with their quality of life. And this shows that the weight has a significant effect on quality of life as well. If your treatment option is going to increase weight, it's going to have a negative impact on quality of life. Therefore, when you select your treatment option, think about a weight gain as well. I think I discussed most of the thing. So how to improve health-related quality of life while managing the diabetes and achieving target. And the most important thing is communication. Ask about the quality of life and what the patient's attitude towards a certain treatment options and certain investigation. And you may have to modify insulin regime, and you have to tailor-made when you recommend self-monitoring to suit the patient lifestyle. So in summary, quality of life is an important treatment goal in patients with diabetes. It's as important as achieving glycemic targets or lipid targets. Simple regime has less impact on quality of life. Once a day or maximum twice a day is probably preferred initiating point of patients who require insulin. There are no strong evidence to support universal recommendation of SMBG for type 2 diabetic patients who are not on insulin. The benefit of structured SMBG should be considered as part of complex intervention. I mentioned about what the structured SMBG is, and if the patient required to do blood glucose assessment, it should be done properly, and the patient will need a lot of support to interpret these results and intervene with the abnormal results. SMBG is an essential part of managing type 1 diabetes as well as insulin-treated type 2. There's no doubt that there are a lot of evidence to support the recommendation of self-monitoring of blood glucose level for this group of patients. Lastly, as medical professionals, it's our obligation to guide and teach our patient and advise when it comes to choosing treatment option or investigations option. It's important to consider quality of life issues before you embarking on any new treatment or when you recommend investigations. So the treatments or investigations which have minimum or no effect on the final outcome and also has detrimental effect on the quality of life should be discouraged. Thank you for your patient listening.